Hello and greetings from the International Agency for Research on Cancer. My name is Freddie Bray. I'm the head of the Cancer Surveillance Branch based in Lyon in France. And I wanted to take a few minutes to talk about population-based cancer registries, or PBCR, as a cornerstone of cancer control activities in every country of the world, and indeed in the participating states as part of the WHO Afro region. So I'm going to speak about the rationale for the sustainable development of cancer registry data, what defines a PBCR, how we are working as part of WHO to provide the necessary technical assistance and capacity building in the Afro region, and just end with a sort of brief overview of some of the challenges we're facing at the moment in developing population-based cancer registration, but also, importantly, the solutions that are available either today or in the pipeline that will facilitate the development of registration across all of the WHO Afro countries. So I'm just going to start with just a little bit of background on the current situation. You're probably very familiar that, of course, cancer is now a major public health problem in the world, and of course in sub-Saharan Africa. It's among the 3 leading causes of premature mortality in almost all constituent countries of the Afro region. It's responsible for 1 in 4 NCDs. Cancer is not a rare disease. For example, the estimated risk of a woman in sub-Saharan Africa dying from cancer before the age of 75 is not dissimilar to the statistics we see in North America or the high-income countries of Europe. With rapid population aging and growth, of course, we will see a large increase in the number of new diagnoses, set to double, and the number of deaths to over 1.5 million new cases by 2040 and 1 million deaths. Clearly, to overcome this mounting challenge, we need national cancer control programs, but with that, we need to have national surveillance systems capable of monitoring progress in the delivery of specific interventions. Population-based cancer registries are essential, therefore, in planning and evaluating national cancer control activities. As you may know, unfortunately, at the present time, there is very limited high-quality mortality data on the continent. Surely this is the ultimate measure of progress, and it's often in many of the targets of global initiatives, such as the SDG NCD target. But the reality is that the civil and vital registration systems are quite weak in sub-Saharan Africa, outside of South Africa, Mauritius, Seychelles. So, in fact, a lot of the data that we have at the present time actually is derived from population-based cancer registries in the sub-Saharan African region, and I want to sort of present that in a bit more detail. We have a coordinated approach that really is assisting the development of registries in sub-Saharan Africa called the African Cancer Registry Network, and I'll talk about that in a moment. Just on population-based cancer registries, what they do, well, they are a system of a continual system of data collection, storage, validation, analysis, and dissemination. They collect data on occurrence, characteristics, and outcomes of reportable cancers. As you can see in the diagram, population-based cancer registries collect data from all institutions and from mortality statistics where cancer is diagnosed or treated among the defined resident population. So there must be a system of reporting clinical and pathological data as well as reliable population data. The key thing, I guess, is that the registries can then really give an opportunity for policymakers to see what the impact is of cancer in the community. It can plan, inform, and evaluate interventions. So it is a best by surveillance system, providing data on incidence and survival by cancer type and stage at diagnosis. It's not an expensive operation. There have been several studies in sub-Saharan Africa showing that it costs around 1 to 2 US cents per case. So it's not expensive, and indeed it's an asset to policymakers. It can assess the current scale and profile of the disease, as well as predict the future burdens, so you can look at resource allocation given finite resources. It can monitor the specific interventions across the cancer continuum, and of course it can benchmark cancer-specific survival by stage to get an idea of the effectiveness of cancer care and treatment in the community. And registries work and have done for many decades on the basis of international standards in reporting and recording of the information to ensure that there is comparable data worldwide. Just on the African Cancer Registry, as stated, we do need, of course, a coordinated approach to sustainably implement registries. And we know that only 1 in 3 countries can report high quality information from incidents at the present time. Cancer registration has been slow to develop in the sub-Saharan African region, but that is not to say the data is not expanding. We really want to make sure that the data is of really high quality and is sustainable in the longer term. In the past decade, really to try and make a step change in ensuring that data is available in every country, the Global Initiative for Cancer Registry Development was developed by the International Agency for Research on Cancer, has many international and national funding and technical partners that really have tried to give new impetus to supporting existing registries as well as aiding the development of new ones. So we've developed at IARC with the GICR and its partners 6 regional hubs that serve as the first point of contact for respective countries, supported by a series of collaborating centres now in each region with specific expertise to provide structured programs across technical training, consultancies, mentorship, analysis to produce scientific or policy documents, and of course the formation of regional networks to assist with the exchange of information. And that's exactly what the African Cancer Registry Network has done over the last 8 to 10 years. It really has made an impact improving the effectiveness of cancer surveillance in the region by providing that technical and scientific assistance to countries, delivering tailored training on the basis of those consultancies in cancer registration, and equally the use of the data, advocating the cause of cancer registration to program owners and ministries. This is very important because very few registries still within the region are actually supported by government funding, and facilitating networks, as I said, of cancer registries. So they're coordinating equally, looking at some of the international research that's possible. There's a lot of interest, obviously, in the scale and profile in different countries, and they're coordinating the work so that the members are involved. And the membership has increased quite substantially over the last few years. Currently, there are 35 member registries in 25 different countries. And just a note on there are defined criteria of quality, including progressive complete population coverage in order to become a member of the African Cancer Registry Network. PBCR in sub-Saharan Africa are all eligible, other than Algeria, which is of course in North Africa. Membership is by invitation upon initial consultancy to evaluate the prospects of population-based cancer registration. And as I said, members initially have to be 50% coverage, completion of the target population in the initial evaluation, and that should progressively rise to over 70% coverage of the target population within 3 years of membership. Just a note on the geographical representation of the members and where they are and whether they're national or not. This is an important issue as we develop population-based registries in sub-Saharan Africa. In fact, only a handful of the current members are national. South Africa is a large population, but it only has a national pathology-based system. But countries like Botswana and Namibia, with populations of 2 to 3 million, they can cover the whole population relatively easily. But most other member population-based registries of the network are subnational. You can see the list at the bottom there, and we're of course striving to develop a network of sentinel registries to make the data more representative, and you'll see in a moment, but in countries like Kenya, Uganda, Nigeria, with large populations, Tanzania, we really need to think about whether it's feasible and is worth the additional finance to actually develop national registries. And hopefully we'll answer that in the next slide. I suppose there is a trade-off. There is a political impetus to develop a national system, sometimes this seems to be the ideal solution, so we can cover the whole catchment population of the country and in relation to national policies. But this is either not technically feasible or the cost involved greatly outweighs any benefits. And this is what the figure on the right is trying to show, the benefits of registration, really in terms of cancer control. So on the y-axis at the top is the benefit to cancer control purposes. On the x-axis is the percentage registry coverage at the bottom. So basically, you will see that at least initially, the benefits are immediate to cancer control after the introduction of one or more regional population-based cancer registries that cover, say, 10% of the total population. There's no hard and fast rules about this, but ideally, the registry area will be selected to ensure that statistics generated can be extrapolated beyond the confinements of the catchment population. With further increments in coverage, the benefits do increase, but only minimally. In fact, it takes to the point of national coverage right at the end of the graphic that you can see that heavy financial investment to realize the true benefits of cancer registration. And that's really useful, of course, for assessment of health service performance, benchmarking cancer survival across all of the local geographic areas that comprise a country. But the expense and the feasibility is the issue. So given the prohibitive costs, most of the requirements, we believe, for planning and monitoring can be achieved through one or more subnational or sentinel population-based cancer registries, and we advocate that approach. We can phase in population-based cancer registration progressively in a system that moves towards national cancer registration. And just a note of where the registries data actually is used and where do we get national estimates. You might be familiar with IARC's GlobalCan estimates. We noted that not all registries in sub-Saharan Africa are of high quality yet, but we're trying to move towards that. But one thing is for sure, that all of the data from the 35 national, subnational registries in the 25 countries are used to make estimates of incidence and mortality in the countries. There's still 16 countries where we have no data, and you can see that in the grey on the right. But this is why we know there are 800,000 cancer cases at the present time, 500,000 cancer deaths at the present time in sub-Saharan Africa. We know that breast and cervical cancer are responsible for 3 in 10 of all cancers in both sexes. The importance of prostate cancer in men. We know this because of the precious data that registries collect, and we continue to argue that it's important to have these estimates for regional global planning, but it's equally important, if not more important, to build capacity and infrastructure for data production, analysis, interpretation within the countries themselves to inform local planning. The knowledge that the estimates are derived from surveillance systems such as cancer registries, or indeed rarely civil registration and vital statistics systems, is a powerful incentive to invest in capacity to record routine cancer data in local settings, we believe. And just ending with some of the challenges, I won't go into these in any great depth, but there are challenges, but they can be overcome. So the current challenges on the left, potential solutions on the right. And there has been a massive increase in the awareness of need for cancer data, has to be said, over the last decades, buoyed by WHO, noting that registries, PBCR, are a core component of cancer control strategy. The monitoring and evaluation frameworks that are coming out from the WHO signature initiatives demand that we have high quality cancer incidence information. If we're going to, for example, look at whether the threshold rate of cervical cancer at the level of elimination of 4 per 100,000 is going to be met in countries. Funding has been an issue. I've spoke about this already. We have costed out population-based cancer registries. I mentioned that the costs, and this is from a study in Kenya, Uganda, and Zimbabwe, the costs at the population level are as low as 1 to 2 US cents per person in low-income or lower-income countries. I've also mentioned the scale issue in terms of national versus subnational. We believe that the focus should be on sentinel sites, not cancer registration in the total population, where the population is large. In populations of 40 to 50 million, we can develop sentinel registries and develop a national system through that. We also collect only a modest set of variables on each case. We don't collect information on risk factors because there are other surveillance systems to do that. So it's a minimal set, and we focus on those to make sure they're complete and accurate. We, of course, we need to train the personnel, and as I've said already, the GICR and the African Cancer Registry Network have dedicated training programs at different levels, at different aspects of the operations of registration that are often tailored to the specific challenges within the registries themselves. Clearly, we need the cooperation of the clinical community and the political will, and it's evident that there should be, from the outset, workshops to engage the specialists and the stakeholders. And one of the key aspects of a cancer registry is to develop an advisory committee, both within the subnational population, but also if there's a network of registries, a national system whereby you bring together the clinicians, the politicians, the stakeholders, academics, patient groups together to examine the progress in the cancer registry and to give advice. This is key as well. Access to information on cancer cases, well, that's a big challenge, given often medical record systems in hospitals are sometimes poor and paper-based in many hospitals. So one thing that we are working on, particularly with the African Cancer Registry Network, of course, but the National Cancer Registry of Rwanda is building and testing a newly developed cancer module in the DHIS2, which is the Data Health Information System developed by the University of Oslo, an open source system that many countries use, in fact, in terms of their health information system. So we're trying to complete an interface that connects the cancer module of DHIS2 to our operating system that registries use called CanReg5. If we can connect those two together, then we're able to hopefully collect individual level information from the medical records of individual patients and connect that to cancer incidence in 5 continents, saving a lot of the laborious efforts trying to abstract information at the ward level, for example, in a hospital. Population-based registries not meeting the IARC high quality status. This is part of our compendium cancer incidence in 5 continents that we produce every 5 years based on the highest quality data, the most complete, valid and comparable data. But again, as I mentioned, there is technical assistance and follow-up by the African Cancer Registry Network and IARC and the GICR, really to try and improve that information by trying to diagnose what the specific issues are and improve the data. And we are seeing progress in that area. And lastly, an important area by itself, of course, is to have accurate cause of death data. I mentioned the challenges at the current time in Africa, but there should be a lot more information and indeed Vital Strategies, who we work with together with Bloomberg Philanthropies, have provided best practice operations for the improvement and maintenance of the ICD mortality coding system within the CRVS. So this is the medical certificate of cause of death. So this is hopefully being improved as well. And this is obviously a key source for cancer registries as well. So I've given a brief overview of the characteristics of registries, hopefully re-emphasized their value. All countries should aspire not just to a national cancer plan, but also an adequate cancer information system. I just want to thank the African Cancer Registry Network and its coordinator, Max Parkin. I want to thank also Vital Strategies, who are implementing the Data for Health initiative of Bloomberg Philanthropies, particularly Maggie Pachowski, who leads the cancer registration program. Thanks for listening, and we'll speak soon. My email and the African Cancer Registry Network email is there. Please get in touch. Thank you.